We want to thank you all for coming today, and thank you all for spending your Thursday morning with us. My name is Dr. Kareem Watson, and I'm the Director of Community Engaged Research here for Miles Square, as well as the Director of Community Engaged Research for the UI Cancer Center. And on behalf of our Executive Director, Mr. Henry Taylor, who's sitting in the back there, who is technically off today, but still lending his time and to be here and support this event, we are really excited to welcome you to the Miles Square Health Center. And just to frame a little bit of context for the day, as you well may know, Miles Square is the oldest FQHC in the city of Chicago, and the third oldest FQHC in the country. And one of the things we pride ourselves on is truly addressing we go beyond social determinants of health here at Miles Square, and we say the multiple determinants of health. And now we even begin to frame the work that we do within this concept of structural violence. And just by a show of hands, not to make this too academic, but how many of y'all have ever heard of this term structural violence before? Yeah, it's growing in popularity, and what we like to summarize it and say is people, places, and things, systems and structures that prevent our population from living their fullest and healthiest lives. And when we think about that, I want to also frame the day in just a brief synopsis for you of some information we recently found out at one of our FQHCs, or our Miles Square clinics on the south side of Chicago, actually through the help of some students here. 87% through this convenience sample survey of about 200 patients, 87% of those patients surveyed were documented as being food insecure. So imagine what that looks like when that provider sees that patient. They may be diabetic, have an uncontrolled hemoglobin A1C or a blood glucose that's skyrocketing, and you write the prescription for the latest breaking, the new innovative treatment, and you send that patient home. You may even send them home. Our providers are amazing. They may even send them to our awesome nutrition staff.
But you can tell me.
This is Siri saying, I had it timed and somehow the other thing hit. And they send them to a nutritionist, but still they go home to a food insecure community area. When we don't like to use the term food deserts anymore, because that sometimes has a negative connotation to the community area, but an area that's food insecure. And so imagine what it could look like if we were able to have a food pantry in that FQHC, and imagine if we could think about food as medicine and have a place and space in that clinic where patients can say, I'm food insecure today, but we can address this social issue by sending you outside, around the corner, upstairs or downstairs, to get the nutrition services that you need. And that not just the food support, but also the education support, the nutrition support, how to cook the meal from a culturally tailored perspective. We take for granted that some of the patients that we deal with may not know how to cook the recipes that we provide. So we're so thankful to the commissioner and everyone else here today, and our Miles Square leadership from Mr. Taylor, and our leadership from the Associate Vice Chancellor of Community-Based Practice, Dr. Robert Wynn, for really creating a space and a place where we can have these conversations. And of course, we're thankful to the Congressman for his unwavering support of Miles Square as an FQHC. So without further ado, we welcome you to Miles Square, and I want to introduce our Chief Medical Officer, Dr. Ian Jasanoff, who will actually moderate the rest of the panel today and take you through what a little bit of the day will look like. Thank you all so much.
Good morning, team. And just to clarify, it's Ian, and he knows that. It's only one F. That was my anecdotal joke for this morning, but I got some opening comments here, and I'm going to expand on what Dr. Watson has said as well. So again, welcome to our first annual, hopefully it's our first and many more to come, Nutrition and Health Equity Summit, sponsored by the Academy of Nutrition and Dietetics. This summit is in collaboration with U of I Miles Square and the esteemed Congressman here, whose mission for health equity has been far-reaching. Thank you so much, Congressman. Interesting comment. According to the Chicago Tribune, in a recent published article in their business section back in the end of June, in the gleaming Streeterville neighborhood, Chicagoans live to be 90 years old on average. But just now, 9 miles south in Englewood, the average life expectancy plummets to about 60 years old, according to a new NYU School of Medicine analysis. This 30-year gap between the neighborhoods is the largest in the country, according to the NYU researchers, who examine life expectancies in neighborhoods in 500 largest cities, based on data from the CDC and prevention from 2010 to 2015. Interesting to note is no solid solutions were offered in this study. Foundationally, nutrition is a key element for healthy lives as well as access to health care. Social determinants of healthcare are conditions in the environments in which people are born, live, learn, work, play, worship, and age that affects a wide range of health, functioning, and quality of life outcomes and risks. According to healthypeople.gov, food insecurity is defined as the disruption of food intake or eating patterns because of a lack of money and other resources. In 2014, 17.4 million U.S. households were food insecure at some time during the year. Food insecurity does not necessarily cause hunger, but hunger is a possible outcome of food insecurity. The USDA divides food insecurity into the two following major categories. Low food security, reports of reduced quality, variety, or desirability of diet, little or no indication of reduced food intake, and very low food security, reports of multiple indications of disrupted eating patterns and reduced food intake. Food insecurity may be term or temporary. It may be influenced by a number of factors, including income, employment, race, ethnicity, and disability. The risk for food insecurity increases when money to buy food is limited or not available. In 2016, 31.6% of low-income households were food insecure, compared to the national average of 12.3%. Unemployment can also negatively affect households' food security status. High unemployment rates among low-income populations make it more difficult to meet basic household food needs. In addition, children with unemployed parents have higher rates of food insecurity than children with employed parents. Racial and ethnic disparities exist related to food insecurity. Here's another interesting comment as well. With regard to patient engagement, and from my perspective, it's one of the most elusive concepts in healthcare. We as healthcare systems can build these brand new fancy hospitals, imaging centers, buildings such as Miles Square. But if you can't get the patient to engage within the healthcare system, true healthy outcomes will not be obtained. According to WHO and its recent document on safer primary care, patient engagement is increasingly recognized as an integral part of healthcare and a critical component of safe, people-centered services. Engaged patients are better able to make informed decisions about their care options. In addition, resources may be better used if they're aligned with patients' priorities, and this is critical for the sustainability of healthcare systems worldwide. That's my opening comments and perspective, hopefully to set the framework for today's next 4 hours of delightful introspection, and hopefully the team here can obviously put forward some concrete ideas. Who are we here at Miles Square? But this is our mission here, to provide holistic quality care in the midst of the underserved urban community. Next slide. Again, like Dr. Watson says, we're one of the oldest FQHCs, and we are a co-applicant with the University of Illinois, which has been a great partnership with regard to our ability to reach our communities and have research projects and to really be very innovative how we see our patients. Next slide. This is our service area. Comprises over 49 of Chicago's 77 community areas that are in need, and we cover the west side, the south side, and areas of Cicero as well. We have 13 clinics. We've got 5 primary care sites, and also something that's very, very unique. We are embedded in with the CPS school districts, which is highly innovative to be able to have those students right there to have those proper care, and their families as well. Our services include obviously primary care, family medicine, pediatrics, etc., women's health care as well. We have very, very innovative programs such as our cancer survivorship programs as well. We are very robust in expanding our behavioral health, optometry, podiatry, our list goes on. Next slide. And again, with regard to our stats as far as who we cover here, but 1.6 million people reside in our service area, and we have an overwhelming number of patients that are Hispanic and African American as well. A significant number of our patients are low income, and we are in the midst of that health disparity that I just quoted here from the NYU study. Next slide. And we have very unique avenues of extending our health care. We now are venturing into our telehealth medicine, and we are going to start now, starting in September, an innovative program for our Diabetic Center of Excellence, where my inspiration was, and I always refer back to the movie Working Girl, of how Melanie Griffith got her inspiration for that merger and acquisition there. But we did not do so well in our UDS measures with regard to our diabetic outcomes. My window faces the university. I look at the university, we've got the best minds out there. Let's form a true diabetic center of excellence to address these needs that in part overlap with nutrition as well. Next slide. And again, we have some innovative programs also. We have our new EHR that will be here 12 midnight, May 9th of 2020. And again, we have our school-based systems here and the diabetic center of excellence as well. Next slide. I think that's, and also last comment here, without Miles Square being what it is today, it's due to Mr. Henry Taylor, and he's been a phenomenal mentor to me, inspirational to help guide me as a healthcare leader as well. But Mr. Taylor, thank you so much, and we very much welcome you back from your short absence. Our first guest speaker is Dr. Terry Mason. Sir, please. The podium is yours.
Yes, no problem.
I can't see them. While she's doing that, let me just take a minute to thank all the organizers. I see some people that we've been in this battle for a long time. I see Dick Wernicke, there he is, back through the days of the National Black Leadership Initiative on Cancer with Dr. David Satcher and others many years ago. And I feel like sometimes I'm stuck in a Groundhog Day because we keep talking about the same things in cycles over and over again. We gave the new names, but the things are the same. We went from disparities now to equity and all this sort of stuff. So let me just take a few moments. Let me just tell you that a little bit about myself. I practiced urology here in the city of Chicago for 26 years, left that, and through the urging of some people sitting in the rooms whose name I won't call, Congressman Davis, I ended up being Commissioner of Health for the city of Chicago, and then was there for a bit, and then went to county as his chief medical officer, and then served as his interim CEO, and now back at the helm in public health in Cook County for suburban Cook County, a population that was not familiar with at all. So do I do this?
I can do this.
Okay, next one. So what I want to do is share some demographic information about Cook County as a whole, and then I may get to our jurisdiction, which is really all of suburban Cook County, everything in Cook County except the city of Chicago. So what I wanted to show you here was some population, some demographics, and you can read those things yourselves in terms of what's happening, but I'm going to spend some time talking about how it's changed. Next. So Chicago's experiencing some changes, and these 3 points about the role of what's happening with suburbanization, shifts within Cook County, both out of the city of Chicago into suburban Cook County and others, and how those things are impacting what's going on in terms of where migrants or people that are coming to Cook County are settling, and how we're suburbanizing poverty. Next. So this return, and I can't see this, so you guys got to excuse me because I can't see it. There you go. So what's happening here is when we look at what's happened in Cook County, you can see that the African American population has decreased by 15%. And if you look at where those decreases took place, you can see that as depicted in the red. Next, that's out of the city of Chicago. But then there's also a sort of return migration within the county where you see blacks particularly have moved to the suburbs, more and more to the suburbs and out of the city. And you can see in the middle of the city, you can see these decreases more readily. Next. And if we look at the Hispanic population, which is the largest growing population in all of Cook County, you can see that there has been significant, and particularly in suburban Cook County, there's been a 50% increase of the Hispanic population in suburban Cook County. Next. So if we look at these particular populations and what's going on, while Chicago didn't see very little change in poverty, but there was a 2% decrease in child poverty. And what happened though is that there was tremendous rises in poverty in suburban Cook County. So you can see as here, you can see in the red where those things took place. And that's in the southern This are the southern suburbs. These are the western suburbs. And you can see also, because of the large immigration pattern of Hispanics, you see those increases up in the northern part of Cook County as well. Next. So if you look at the areas of poverty, because we know poverty is a carcinogen, Dr. Davis had talked about, poverty is at the cause of a number of things. But if we look at where we're seeing those poverty levels as defined by the federal poverty limits, you can see based on these indicators here. This is north suburban, south, southwest, and west suburban Cook County. Next. So we also take all of this into account in terms of how we think about this as a collective. We end up what we call our social vulnerability index. And this is what it really is defined by. Whether or not there's money flowing in the community, what the composition of the communities are, whether or not these are minorities, and then housing and transportation. We'll go through it. So if you can look at this, you can see that the social vulnerability is interesting within different parts of Cook County. You can see that it is the lowest in some of these areas identified in the lighter colors, and higher in those with the darker colors. Next, and I'll give you a little bit more about what that means. This is our Child Opportunity Index score. And this is a composite of measures that talks about the education, the health environment, and economic status. And so what happens is, if the areas are with very low colors, that means that there's very little childhood opportunity for growth and development. And if you see the other colors, you can see that these colors are where we have a lot more opportunity, and it's sort of scattered. This is the north. This is lakefront Chicago. County is home to some of the richest places in the United States and the poorest, all in one county. Next. But this sets up what the challenges are going to be. And when you look at these, look at where these things are. And if you look at where those opportunities are spread among the different ethnic groups, you can see that there's this dispersion among those opportunities among the different racial groups, as much of you, many of you would already know. Next. We look at life expectancy by birth in Cook County. You can see in the areas of red that this, if you were to reimagine and superimpose where we have low opportunity indexes, you can see those same areas almost superimposed on this same map. So you can see that life expectancy of 85 years is in those areas of the city and the county where you have better economics, and lower in those areas of the county. And this is Maywood right here. These are the areas where there are significant issues. And unfortunately, I don't have time to go through any of them, and I'm sure the former commissioner and Congressman Davis can speak more to these, because this is not new. This is old. Next. And if you look at income versus life expectancy, where the highest quintile is the little green dots, you see them clustered in the same areas that you saw the other data points that we talked about. And the lowest ones are in the same areas in the south side of the city of Chicago, south and western parts of Cook County. Next. Then when we look at mobility, because that was one of the indices, looking at who has a car. And obviously in the city of Chicago, that's not as much of an issue from one point of view because of the transit system. But in the suburban areas, you don't have the same kind of robust systems. And so, as I've been working in this area, it became really clear to me, you can talk about foods, you can talk about grocery stores, you can talk about all of that, but if people don't have a way to get there, it doesn't matter. And if you look here, this is the people in pink are the ones that more of those people don't have vehicles. And if you can see where they have vehicles, more in the city, and there's some out in the southern suburbs, but up in some of these areas that are frequently now inhabited by, particularly new Hispanic folks coming into the county, you can see that many of them don't have vehicles. And as we look at we do what is called APORS in the Department of Public Health. That's our Adverse Pregnancy Outcomes Research Group. And basically they have a state mandate. We are given every name of every child that's been born with some genetic or some sort of abnormality. And those children are required to be visited by our nurses every 2, 4, 6, 8, 12, and 24 months to check on their progress. And so you can imagine our nurses we're based down here, you have to span the entire length of the county to visit and check on those children. Next. So I'm going to just briefly go through this. None of this is going to surprise you. Next. So this to me is the leading cause of death and disability and poor nutrition in the United States. It is the plethora of processed foods that do nothing from one point of view but aggravate the so-called leading causes of death. And I say so-called because I have perhaps the singular opinion in this room that this is the major cause of what we have in terms of why we have the diseases we have. Particularly things we're calling stroke, diabetes, hypertension, and it's what we so-called cardiovascular disease. These are all dietary diseases. And there may be some debate about that, but the amount of those diseases that have a genetic cause are minuscule, composed as opposed to, this is a picture that comes out of a book called What the World Eats. This guy went around the entire world taking pictures of a week's worth of food of different people all over the world. This was not the picture for blacks, this was the picture for the United States. So this seeing all the processed foods here, and if we talk about fruits and vegetables, I think there's 2 tomatoes here, there's some grapes right there. But most of what we're eating, none of this is even real. Most of these things are processed food products of one type or another, which are inflammatory. Next, if I have my time, I'd go into that a little bit more. And so what we see, particularly in communities where those things are far more abundantly than in other places, and what you can see here, this is these mortality, the so-called heart disease. And I keep saying so-called because I don't believe it's heart disease anymore. I believe the problem that we see, and I can show you this in another talk, but the thing that we're calling cardiovascular, first of all, there's no such thing as segmental vascular disease. If you have any kind of blockage or inflammation anywhere in your vascular tree, you have it everywhere. Everywhere. And this whole notion that we are been fooled into think about this in terms of symptoms is absolutely the most backward way to think about diseases, because there's no disease, even so-called cardiovascular disease, that actually gives you a symptom in its earliest stage. When it's just vascular endothelial inflammation, you won't have any symptoms. And the other thing is that, and the reason I left the practice of urology is because I wasn't curing anybody of anything. I managed their disease. I did not cure. And that's what we do in places like this, in places like county and all the other things. We manage complications. That's our job. And for people to think that they should come there and get cured, that's not an expectation that you can expect. And so when we see these things, this is particularly among the different groups, you can see where those things fall. Next. And it's the same thing, it's similar kind of things for all of the different diseases. Why? Because at the core of them, this is why nutrition is so important, because that's where we can intervene at the level of cure and prevention. Next. And the same thing for stroke. These are the same sort of things. And you can see that the same groups have the same, and I can tell you, I could go back 30 years or 20 years, show you these same graphs, and it will look almost the same. Next. So this to me is the real pharmacy. If we're going to begin to do anything to really, even from a medical point of view, because now we're seeing all kinds of things happen. I mean, even putting vegetarian hamburgers in Burger King. So so people are getting the message, but we need to equip our dietitians, first of all, with the ability to talk about this more, and secondly, to pay them for what it costs to do that. So when they get a patient who's under these extreme chemotherapy regimens that we almost kill them with in our hospitals, and they come in with sarcoplexy where the muscles are being wasted, and the doctors told them just give them another can of Ensure, that's not the truth. That's not what should be happening. And they should be empowered to use and be paid for prescribing, because here is the real pharmacy. We got things here called phytonutrients and all kinds of things. These are the only things that will counteract the inflammatory problems that we're seeing that are and there's another slide that I thought would be a little too technical for this group, but it's talking about TMAO, trimethylamine. And we know that these things, these inflammatory markers now are at the core of looking at what we call vascular disease, what we're calling cancer, things of that nature. And the only thing that does anything for those is this. That's it. Next. Last thing, this last part. Next. These are infant mortality rates. This is something that we've been talking about forever. Why are black infant mortality rates? But it follows everything else that blacks have, worse than everybody else. And there's a lot of that that's historical, and some of that we have to fix next. And so low birth weight babies, this is another thing that we're beginning to look at. We're going to have a symposium across the street in the new professional building at the county, where we're going to be looking at this differently than we've been looking at before. Next, and I'll show you that in a minute. Preterm births, same sort of thing. Next. And lately, we just finished up the first phase of our sexually transmitted infection campaign. Next, and I'll show you why. This is why. We have, this to me is a bioterrorism epidemic, sexually transmitted infections. This is the largest, the highest number ever of chlamydia cases documented in Cook County. Most of them female, and the reverse is true for gonorrhea, where it's mostly male, 58%. So we took on a program and we did some things. We partnered with GCI to get folks to come out and get screened and get tested next. And if we look at where we're seeing this disease, here's the same kind of maps all over again. This is south side of the city of Chicago. This is west. Maywood is a hotbed right there. And then you see the southern part of Cook County. That's for chlamydia. And next, and show it. Keep going. Keep going. Those are hotbeds. These are the gonorrhea numbers. And I mentioned those already. But again, these 58% of these cases are men. Next. And the problem with gonorrhea is we're now at a point where all the drugs that are used to treat it are almost, the gonorrhea is almost resistant. So we've got some real problems, and we want to think about that, and I'll tie that together in a minute. Here's the same heat maps for gonorrhea as we showed you for chlamydia. Next. Keep going, those are hotbeds. So the one thing I did want to say about these particular issues, and we, like Mile Square, also we do food insecurity screenings on all our patients. We actually started small farms that we're working on in addition to working with the Greater Chicago Food Depository, partnering with Black Oaks. Not only do we talk about making sure we get a screen, but our patients walk out with a bag of food. And they also walk out with bags of food that have been looked at by our dietitians and other people to make certain if they are renal patients, that we've looked at the phosphorus and the potassium and what have you, and tailored those things for that. And I got a whole other presentation I can give on that, but time won't permit that today. But these things here about population shifts, as we think about the workforce, who's going to do what, how do places that hire people will need to change in order to deal with the changing demographics of our workforce, and who are we going to work together with at the federal level, state level, local level, and begin to think about how we combine. These diseases do not have boundaries, and the things that cause them in one place cause them every place. So we got to think about how we do this a better job of doing that. I think that's the last line. Next. Yeah. So I asked you just what we can do, and this is on our watch. This is our watch. All of us in here are responsible. And one of the things that we're looking at with the summit, the conference that I talked about, infant mortality, there's data that talks about whether or not chlamydial infections induce premature labor. There are other things that we need to look at and study to get data to understand how we guide our interventions based on what the data shows us. And I think that's my last slide. Next. Yeah. Thank you. And I'm sorry for going through that really fast, but it's a lot of information, and I actually cut it down. That's half of what I had. Can I take questions or no?
I think we're going to have a panel discussion,
Okay.
so let's have you,
Okay.
well, we can then circle back with that. Our next speaker is to give us the Illinois perspective, but Dr. Ezeki.
I'm here on your behalf.
Oh, so we have a Academy Award winner to go in the place of that speaker, and you,
Juana, I can introduce.
Please.
That's fine. Thank you. Yeah. Good morning, everyone. My name is Juana Ballesteros. I'm with the Illinois Department of Public Health. Director Ezeki sends her regards. She was unable to be here. She is attending a conference in Colorado. And so thank you for having me here today. Thank you for the Academy, Miles Square, Congressman Davis, for putting on this very important event. I didn't realize this was the first event of this kind, so I'm really looking forward to future events, and more than anything, I think actionable things that will come about from our conversations here today. So the event organizers asked me to touch on three particular topic areas. One is providing some prevalence data. I will say this, I feel like I'll be preaching to the choir if I spend more time than is needed on prevalence data, but I really want to get into what I think is the meat of today's event, and the purpose is talking about social determinants of health, but I think also more importantly, and Dr. Watson touched on this as well, is talking about and rethinking the way we tackle equity is talking about the structural determinants of health inequity. So I'll talk a little bit about that and the policy implications of that, both at the little p level, which is organizational policy change, but at the big P level, which is more like laws and legislation and ordinances. So that's where I'll spend the meat of my time talking today. So we have prevalence data here, and I did not break this down by race and ethnicity. We all know, as Dr. Terry Mason mentioned, we know that racial and ethnic minority groups are much more disproportionately impacted by chronic preventable conditions, right? And so you see on the right, I have Illinois data, and you'll see on the left, I have data for the whole country. Interestingly enough, when I was putting these slides together, not big differences between Illinois prevalence and for the whole country. I think we all know here in the room that diabetes is a huge problem in our country. Especially type 2 diabetes. 21 million US adults in this country have a diagnosis, and I quote, diagnosis of diabetes. That's 8.6% of the US population. I want to hone in on why I say diagnosis, because there's another 7 million US adults that don't know that they have diabetes. 7 million. So that's a third of those that do know their diagnosis. I want to further stress the fact that there's 84 million adults in the US. That's a third of the US adult population, a third that have pre-diabetes. I think a lot of times we talk about, chronic disease management and treatment, and, Dr. Terry Mason also touched on this. We need to also rethink about more of our efforts going to prevention and screening folks for pre-diabetes and intervening right then and there, intervening before folks have pre-diabetes. So a little bit about obesity. I can't quite see it there, but about a third, close to a third of US adults have obesity. This is not overweight and obesity, this is obesity, about a third. But when you look at both overweight and obesity, nearly 2/3 of the US population. And I think the last time I checked my BMI, I'm overweight. I've been overweight. So we can have a whole conversation about BMI, but obviously we all know that that's a big problem here in the US. I'm gonna skip through cardiovascular disease and jump right into social determinants of health and social and the Healthy People 2020. I think many of you might know it's our nation's 10-year prevention agenda. This 2020 agenda was released in late 2010, so we're kind of coming to the tail end, and Healthy People 2030 should be coming out later, later this year, next year rather. Interestingly enough, with Healthy People 2020, there was a number of new topic areas, which is very exciting. They included adolescent health, LGBTQ health, and social determinants of health, to name a few. I think in doing so, the folks that put together the agenda acknowledge the fact that, health starts in our homes, our schools, our environment, in our workplaces, and the neighborhoods that we live in. Definitely highlights that our health, in large part, is determined by our access to social and economic opportunities, the resources and supports that are available to us in our homes, in our communities where we live and work. It is definitely impacted heavily by the quality of the education that we receive, or access to education, the cleanliness of our water, the safety in our neighborhoods, our social interactions, and relationships, just to name a few. We want to ensure that all have the opportunity and advances needed. And what that means is, if we're going to tackle social determinants of health, advances need to be made not in healthcare only, but in the fields of education and housing, transportation, just to name a few. So I think many of us have seen this great graphic of social determinants of health, and you'll see there that there's kind of 5 specific determinant areas that that kind of make up the social determinants of health. And in Healthy People 2020, each of these determinant areas have specific measurable, actionable objectives that are related to the underlying factors of social determinants of health. So, we all talk about, social determinants of health, the issues that we see in our communities that many of us might experience ourselves, but very, kind of on a positive note, there are emerging strategies to address social determinants of health. One of them is health impact assessments, and another emerging, and some might argue not so emerging, is health in all policy strategy. Interestingly enough, they both have the same acronym, HIA. So health impact assessments and health in all policies. There's kind of one key difference between the two. So health impact assessments are, as you can see there, is a way to assess the possible health implications of a possible policy, program, or plan. So it's very proactive. We're looking at proposed policies, right? And the sweet spot, again, is that it's very proactive, and hopefully findings from this health impact assessment will help, maybe tweak a proposed policy to make sure that, we account for any possible negative health implications, in particular for already vulnerable, disenfranchised populations. It identifies harms and benefits, like I mentioned. It definitely increases transparency when it comes to decision making. I think we all, can argue and say how, many times decision making is done behind closed doors. And so this definitely increases the transparency of decision making. It supports inclusive and democratic decision making process and shifts the decision making from an economic one to more of a quality of life framework. So health in all policies, very similar to health impact assessments, but this assessment of possible health implications of any policy or program is done anywhere in the trajectory from, the proposal state to, the middle of implementation, as well as during an evaluation phase. So those are the main differences. Both promote health, equity, and sustainability. They support deep and ongoing intersectoral collaborations. I cannot stress that enough. I think we all can say that we're guilty of working in silos, right? We all know how important and the benefits are of working across offices, agencies, departments, across disciplines. But it's easier said than done, right? And so by implementing health impact assessments or health in all policies, we are really intentionally working across offices, across agencies. It's not just, IDPH working alone, but working with, ISB, Illinois State Board of Education, with our, corrections department, transportation, so on and so forth, because we're helping them to identify possible health implications of their decision making. Engages stakeholders. I can't stress that enough. Really, this calls for us to get out of our comfort zones, to go and talk to the folks who will be directly impacted by our decision making. It's folks that live in the surrounding communities. It's our patients. It's those that are the end users of our decision making. And so this process really calls for, again, engagement of those individuals, and really creates structural change in the way that we do our everyday work. So I'm happy to say that here in Illinois, our Governor J.B. Pritzker, very recently, and I mean about 2 or 3 weeks ago, signed into law, the Illinois Health in All Policies Act, which actually will start to become law January of next year. So this act creates a work group to review legislation and to make new policy recommendations related to health of Illinois residents. This work group will examine the impact of health from all of these different sectors, right? Those that we've talked about that are, the social determinants of health, from housing to education to our justice system, so on and so forth. This work group will have representation from leadership across different state agencies, those folks that are doing the work of housing and education in our justice system, so on and so forth. They will review and make recommendations regarding how health considerations may be incorporated into the decision making that all of these agency heads are doing, and will also develop laws and policies to improve the health and reduce health inequities. This is a very not the best graphic, and I apologize. The far ends were cut off, but this is a great representation of how a Department of Transportation has taken a health and all policies approach to their decision making. Active transportation, just so we're all on the same page, is a means of getting around that is powered by human energy, which is primarily walking and bicycling. And so the Department of Transportation, in ensuring that they're impacting health in what they do in their planning for transportation, wanted to make sure that whatever built environment changes they made, it was conducive to folks engaging in physical activity. And in doing so, they know that they would reduce obesity and overweight rates. They would reduce the prevalence of chronic illnesses and ultimately improve quality of life. But at the same time, they're also improving air quality, which will also, we know, reduce respiratory illnesses. So I'm going to show a video of this wonderful urban greenhouse in North Lawndale called Farm on Ogden. And this is a great example of little p, or policy change at an organizational level, even at the community level. And so I won't do it justice by explaining this wonderful urban greenhouse, which just opened in June of last year. So.
Hard angle.
Thank you.
The Farm on Ogden development will create a resilient, sustainable local food system. We acquire the land, grow the food, distribute that local produce, and we provide job training and wellness education. All of the components of that space and all of our partnerships were really developed with thinking about three things: food, health, and jobs. We will also expand our unique training and certification programs in farming, food safety, culinary arts, and entrepreneurship. We're going to take an existing program and existing partnerships, bring it all together, and build on what we know already works. It's not just about the pounds of produce that we're growing. It's also about access, and it's about access for communities that don't always have available produce and aren't always thought of in the food chain. We launched the Veggie RX program, providing boxes of produce, nutrition education, and cooking classes to patients in Chicago's North Lawndale community.
This is a program we were fortunate to be able to participate to allow us to experiment with writing prescriptions for food for our patients. In North Lawndale, for example, the rate of diabetes is 3 times the national average. Diabetes, heart disease, high blood pressure, all of these things are directly linked to what we eat. Rather than just doing reactive medicine, treating the diabetes with a pill, and do some prevention or even treatment through food, that's the future.
Everything we do is about getting food out of the ground and onto your plate. With the Farm on Ogden, we know we can do even more. Just imagine how we can grow.
I saw some folks kind of smiling. Did you see some familiar faces? Are you guys in the video?
Yeah.
Oh, wonderful. Well, keep up the wonderful work. And so Farm on Ogden, I think among the many things that it does provides job training. We know jobs and unemployment and training opportunities is definitely an issue in particular in North Lawndale, but so it's doing that, but it's also providing fresh fruit, produce to the community that is food insecure, but also through their Veggie RX program, Lawndale Christian Health Center is directly providing prescriptions to folks to take advantage of the produce, also receive education on how to eat the produce. So I would be remiss if I did not have this slide, which we've talked about this and we'll continue to talk about this throughout the day, that we know that disease is a social production. It's nothing new. W.E.B. Du Bois, over 100 years ago, quoted as saying, our field was founded on this kind of understanding of the social roots of health inequity. It's embedded in our systems and our structures. So now shifting gears to talking about the social determinants of health inequities, if we reflect on the social justice roots of public health, we know health equity is our central goal. If we are serious about health equity, we need to make sure that we are working to assure that everyone has the social and economic conditions they need to have optimal health. If we are to assure conditions for optimal health for all people, this requires that we value all people equally, that we recognize and rectify our historical injustices, and that we provide resources according to need. So, show of hands, who is not familiar with the downstream, upstream analogy? Who is not familiar with this? So everyone's familiar. Wonderful. So, what this calls for is that, we look at the root cause, right? In this case, it's people who were found drowned at the bottom, downstream, folks trying to save their lives. They can't seem to save enough people. And then they say, well, maybe we should hire more people and pay people to help us to save lives. Or maybe we should have a signage that says, be careful, But, the public health approach is looking further upstream and asking, why are people even falling into the river or jumping into the river? Like, let's get to the real root cause. And that's what's looking at the structural determinants of health inequity calls for. Tackling social determinants of health is great, but really if we're going to make the biggest impact, we have to look at structural determinants of health inequities. And what that means is we have to look at how they came to be, and it's a result of power and privilege. This is my very last slide. I think many of you are familiar with this. If you, go to the far left, you'll see there that it's this wonderful analogy of, the ground that these three kids are on is uneven or unequal. And so they're given the same size box, which is, equal, not equity, right? So they equally have the same size box to stand on, but again, they're still at a disadvantage because of the ground that they're on. And then also looking at the fence is different heights as well, right? So they're not starting at the same advantage. In the second slide, you'll see they're given equitable resources, right? So based on their need, as you can see there, they're each standing on different size boxes. But in the third slide, the individuals work together to dismantle the symbolic structural barrier, which is the uneven fence. In our health equity work, we are ultimately aiming to do this, to dismantle social injustices and barriers. Thank you.
Thank you so much. Our third speaker is from the Academy of Nutrition and Dietetics, Ms. Sharon Cox.
First, I just want to thank everyone for being here. As a member of the Academy of Nutrition, this is an exciting opportunity to have this Equity Summit. So let me start with a quote. And think about it, I'm focusing on Dr. Mason. Coming together is a beginning. Keeping together is progress, but working together is success. And I think I heard you say that we've been talking about this for a long, long time. And I see it, and I think the Academy members here see it. This is an opportunity for us to work together. And it's going to be multi-pronged. It's going to be a multi-pronged approach. but we can work together to address health disparities in our community and not only achieve equity on a local level, but we have people here that can help us achieve equity on a national level. So again, as a registered dietitian and a board member of the Academy, I am really excited about this opportunity, and I know we're going to have great outcomes at the end of this meeting. I know that. So let me tell you a little bit about the Academy, because we feel that we are great partners in this journey. So the Academy of Nutrition is one of the largest food and nutrition professional organizations in the country. We were founded in Cleveland, Ohio in 1917. So that means we've been in this fight for over 100 years. So you have partners that have been in this fight for 100 years. And it was visionary women dedicated to helping the government conserve food and improve the public health and nutrition in World War I. So that's why the Academy was pulled together. Today, the Academy represents over 100,000 credentialed practitioners, including registered dietitians, diet technicians, and other members with advanced degrees, and we also have student members as part of the association. What I want to focus on is that people sometimes think dietitians are only in the hospitals, but let's talk more about our vision for global health. The next slide shows that the Academy is committed to improving the health and advancing the profession of dietetics through research, education, and advocacy. We feel that improvements in global health and well-being through nutrition is important. But more importantly, we envision a future where all people thrive through the transformative power of food and nutrition. So we have a more global vision of how all people can thrive through transformative power of food and nutrition. Members of the Academy play a key role in shaping the public choices, thereby improving nutritional status and offering treatment for illnesses and injuries. Our members offer preventive and medical nutrition therapy in countless settings: healthcare systems, home health, food service, business, research, and educational organizations, as well as in private practice. A member of the medical team in hospitals, we provide medical nutrition therapy using specific nutrition services to treat chronic illnesses and injuries. Our community-based dietitians provide health promotion, disease prevention, and wellness services, including those targeted at women throughout their life cycle. So the nutrition that we provide is in all settings. And the next slide, we're going to look at how do we pull this all together. And so it's back to what I heard this morning. We looked at what's happening in Illinois. We looked at the social determinants of health. But how do we pull this all together? This model was shared by one of our members, who's the chair of NOBADON, which is the National Organization of Blacks in Dietetics. And it looked at 5 areas that if we touched all of those areas, collectively, we can improve health equity. So imagine everything that we talked about, if we pull it together, if we had a strategic plan around this, these would be the areas that we would look at. First, we talked about food security, but we're putting that together with the assisted federal programs. How do we address food insecurity? By putting together a force around making sure we have assisted federal programs. Also, we're looking at food industry marketing. That photograph that we saw with how the table for Americans look, it has a lot to do with the food industry and the marketing. What can we do to address that? Nutrition intervention and prevention, we are the experts there, and I'm going to talk briefly about what we can do. And then lastly, medical nutrition therapy. And I think that's missed by a lot because we see health promotions and we know about the dietary guidelines, but we can go beyond that. We can do personalized nutrition care. And we want to emphasize the importance of that. As Academy members, we can provide that. But more and more, we need our partners to refer to a dietitian to provide that care. Next slide. So we talked a lot today about disparities in food insecurity. And we know that in our country, and these are the USDA numbers, that 11.8% of US households are food insecure. And then another 4.5% are very low food secure or very low food security. These negative outcomes associated with food insecurity across the lifespan really warrants attention about what can we do to make sure that we address these. And I think we heard clearly that Healthy People 2020 has two objectives around food. One is really to reduce household food insecurity, and by doing that, reducing hunger. Also, we're looking at eliminating very low food security, especially for children. So when we look at food insecurity and what we can do, we're trying to reduce the household food insecurity, but also looking at what can we do for children. Next slide. This slide, it may seem a little complicated, but it really talks about food insecurity by race and ethnicity. And if you look, you can see that food insecurity by Black and Hispanics are much higher than all households, and especially white households. So that top graph where you see the blue and orange line are Black and Hispanic households, whereas the green line is all households, and the purple line is white households. So again, it goes hand in hand, food insecurity and race. So what are we going to do is the question. And we have quite a number of programs in place now, but we need to ensure that these programs stay in place. Next slide, please. So most of you have heard of the Feeding Assistant Program, and we have one here, Women's Infant and Children Program, or WIC, or the Supplemental Nutrition Assistant Program, or SNAP. Even the National School Lunch Program, we've heard of all of these programs, and they were certainly put in place to ensure food security in our communities. But even yesterday, I received a text that said, please talk to your congressperson about not letting them cut the school lunch program. And so even though we've had the vision of what we need to do, we need to continue to fight to ensure that these programs stay and that this will address some of the food insecurity that we see. So everyone in this room can work together to help support that, and I'm sure we're going to hear much more from our congressman. Next slide, please. This is interesting, and my colleague shared this with me from Nobadan. We never think about the food industry. And probably if we're looking at partnerships, we need to have someone here from the food industry. Because what we're seeing is that, and this was a report done by Yukon Rudd Center for Food Policy and Obesity, Black and Hispanic youth are exposed to more food advertising in the media and in their communities compared to white youths. And guess what they see? They see the fast foods, and we saw that on the picture, candy, sugary drinks, and snacks. Also, we're seeing a lot of money being spent on Spanish targeted and Black targeted networks, such as Univision, Telemundo, BET, and VH1. So this study showed that we're educating in our schools, but you go home, you turn on the TV, and you see all of this marketing around fast foods and sugary drinks. And I know there's been a lot of work in the food industry to cut back on high sugar products, but there's more that we can do in partnership to talk with our partners in the food industry, because again, they're targeting a population that really is predisposed to chronic disease. Next slide, please. So I hope I'm not going too fast, but when I brought the model forward, I said we needed to look at food insecurity, federal programs, we're looking at marketing, but then what are we doing with regards to prevention? And I think everyone has heard of the dietary guidelines. And so these guidelines are really science-based recommendations for a healthy approach to nutrition. They are updated every 5 years, and they are currently being updated. We're so proud as dietitians to have quite a number of individuals as part of that review board. And what we're doing is developing guidelines that could be adaptable to different cultures. But unfortunately, what we see is that most individuals fail to meet the dietary guidelines. So when we talk about prevention in our communities, we do need to look towards the dietary guidelines, because there is an opportunity to help communities live healthier lives, and we can be consistent in our message if we embrace those dietary guidelines. And I think I heard a lot about mothers in the early stages, how important it is. And one thing that we see is that the poor diet of mothers during pregnancy is concerning, given the growing body of research on the impact of maternal diet on fetal programming and predisposition to chronic diseases. Early life nutrition is important to influencing the risk for disease in adulthood. Racial, ethnic minorities, particularly Black and Hispanic women, and educationally disadvantaged groups are less likely to adhere. And so that's the point. They are less likely to adhere to dietary guidelines than their white counterparts, leading up to their first pregnancy. And so what we're saying is, and I'm hearing root causes, they need to learn about the dietary guidelines early on before they become pregnant. And if they are equipped nutritionally, that really sets their children up to having a brighter, healthier future. So the dietary guidelines really don't get a lot of attention in the communities, but we do need to raise the level that people understand the importance of those guidelines and the research that goes into that. Next slide. There's a lot of great programs on the community level. And as we discussed earlier, the clinical dietitian practice in many settings, and we have great examples in our community with regards to those programs that meet the individual where they are. But the most important thing, it has to be culturally and economically appropriate. And I'm very proud of a group of dietitians that are part of the academy. Next slide, Nobadan. And I wanted to highlight two things that we're seeing. First, we do have quite a number of credentialed dietitians from a variety of different backgrounds. And to develop things that are culturally sensitive is very important. And we work in that area to ensure that we have general information, but that we, when talking to individual patients, that they are culturally appropriate information. So Habini, I don't know if anyone heard of them, but they were formed in 1995 to educate high-risk, culturally diverse population about nutrition strategies. And one of the things they did very early on was to develop the soul food pyramid. Does anyone remember that? So the soul food pyramid took the dietary guidelines and then said, how does the food that you eat fit into those dietary guidelines? And so now across the country, we have a way of explaining to individuals from different backgrounds how to incorporate those dietary guidelines into their food pattern. So back to how we all can work together, we really need to ensure that we bring in partners. And so the Academy of Nutrition and Dietetics said we are excellent partners because we are dealing with things at the grassroots level, and we are making sure the information that we provide is culturally appropriate. The other group is the Eat Well Exchange, which is a 401c. And one of the great things about that group is that they do target young people, and they have nutrition messages that come out every day to motivate individuals to eat healthy. And what a difference have we seen in that immediate area where you get the text from the Eat Well Exchange. Again, we have many dietitians working in private practice in the community that are doing great things to ensure that our young people especially understand the importance of nutrition, and it really helps us deal with the issue of health disparity. Next slide, please. Lastly, and I alluded to this earlier, dietitians provide nutrition education. And nutrition education really is the reinforcement of basic or essential nutrition-related knowledge. But we want to emphasize medical nutrition therapy, which is individualized, and it includes a nutrition diagnosis, therapy, and counseling services for the purpose of disease management. And it is furnished by a registered dietitian or nutritional professional. So the difference is almost like a strategic plan for that individual. Because I know a lot of times in the community, we're providing great information, but the information is not targeted for the individual. And what we're seeing is that medical nutrition therapy now is mainly provided to those seniors that may have diabetes or renal disease. But they could be, or that service could be available to many more individuals. But our physicians are sometimes not referring our patients for those services. And we want to encourage them to really refer to the clinical dietitian for medical nutrition therapy. We have a lot of studies that were done, but what we're seeing, even in the renal population, that if you had medical nutrition therapy, you could delay the onset of dialysis for 12 to 18 months. So that little intervention can improve the quality of the patient's life and reduce healthcare costs. Also, when you look at Medicaid, medical nutrition therapy is not consistent from state to state. And it is possible that only those with diabetes or other chronic diseases get their care in the community. But the Academy is really focused on pushing for medical nutrition care and ensuring those who need it have personal care or personalized medicine. So if we were to hang our hat on one thing that is really important that will help in this fight is medical nutrition therapy. Yes, we do nutrition education. We're in the community, but medical nutrition therapy is that personalized medicine that can really make a difference. So let's go back to the model that we talked about. That's the last slide. The purpose today is to look at how we all can work together and to clearly understand the impact areas. And yes, nutrition is part of everything that you see here. But what's most important is the need to focus on the disparities in the community and bring collective groups together to address that. The Academy is very excited to be a partner. We're experts in food and nutrition, and we welcome the opportunity to help join this fight to decrease health disparities. So thank you.
Sharon, thank you so much. Our last speaker of the morning needs no introduction. He's been a wonderful champion for FQHC in Miles Square as well as throughout the country as well. But Congressman, please.
Thank you. Thank you very much. You know, I bargained with life for a penny, and life would pay no more. However, I begged at evening time when I counted my store. But life is a just employer. He gives you what you ask. But once you have set the wages, then you must bear the task. I worked for a menial hire, only to learn dismayed that whatever price I had asked of life, life would have willingly paid. You know, I have learned so much this morning, and I often smile when I'm listening to Terry Mason, because he makes me feel like I ought to be back in school. But really just being here at Miles Square. I remember when Miles Square was in a 2-story house. 2-story, 1 floor, 2nd floor. That was Miles Square. That's where it started. That's what it was. Just a 2-flat over on Washington Boulevard. And then we see what it is today and what it represents today. And it means that somebody has had a lot of faith. And when we talk about change, we know that change is difficult. We know that getting people to change their eating habits is very difficult. I know the difficulty that I had changing my smoking habits when I used to smoke 30, 40 years ago. And then I thought of how it happened that we smoked. When I was a college student, the most popular guy on campus was the sample man. And he gave away these little samples of cigarettes in a package. And there were 4. And we never thought much about the fact that somebody was orchestrating our behavior, that's what was going on. I finally decided to quit when I went to visit my father one day, and I didn't have any cigarettes, and I said, "Give me one of your cigarettes." He said, "Cigarette?" I said, "Yeah." He said, "Oh, I don't have no cigarettes." He says, "I stopped smoking a couple years ago." He said, "If food would do something that he knows is going to hurt him. And once I discovered that smoking was not good for me, he said, I quit. And I think I said, if my father can quit and not be a fool, then I ought to be able to quit and not be a fool. The last 2 weeks, I've had so many great experiences. I visited with two ladies, both who were 108 years old. Matter of fact, some of you, if you watched the news on Saturday, you may have seen me with one of them on Channel 7, I think it was. 108. She was not in such good shape, but she was still doing all right. But the Saturday before, I visited with another lady in Maywood, Illinois. We just mentioned Maywood. She was 108, but she was in a setting like this one. And of course, she didn't require any help. She didn't need any assistance. She had on a beautiful outfit, bright yellow. As a matter of fact, I even took a photograph with her. And I said, 108. And so I asked her, how do you manage, how did you happen to live to be 108 and in good shape and live alone? She has a homemaker who comes in 2 days a week, and she prepares her own meals and do all of the things, and she resists any attempt to be anything except self-sufficient. I'm saying people just, no, I'm okay, don't. And she say, I think it's because I don't worry about a lot of stuff. And she said, I never did. I just kind of take life as it is, plan for the things that I want to do. And of course, she mentioned the fact that she had a lot of faith. And I thought of faith when I was looking at the slide, and we were talking about what the folks had accomplished over on Ogden Avenue. And Wayne Gordon, who really was a high school coach before he took over all of that and developed it, and all of what they have, the North Lawndale Health Center, the food processing, the gardens, and all of that. And so Wayne must have had a lot of faith that he could do this stuff. I mean, he was coaching kids at Farragut High School. And it also just happens that I spent yesterday with my counterpart. I serve as chairman of a subcommittee on the Committee on Ways and Means that really decides a lot of stuff about money. I mean, who pays what? And where does it go? And I brought my, what we call ranking member, over yesterday to kind of show her some of the things that we do with low-income people and some of the things that we do with children who are vulnerable and in need of help. So we went to the New Moms Center over on Chicago Avenue. Great program for young mothers and their children. Fantastic. We also visited with the Safer Foundation that works with people who have been in prison and come out and are in need of assistance to successfully reintegrate back into normal society. And of course, many of us don't realize how many of those people there are. There are about 60 million in the United States. And so it's much more than, poo-pooing them down in the alley. It's a whole lot of people. We ended up at the food depository. That's where we spent our last hour. And then I ended up sitting with the dietitians and nutritionists at a table last night. And so I've just been around this discussion for the whole 2 days. The whole 2 days. And I think it is so important. I must admit that I focus much of my thoughts and ideas on prevention. My mother used to tell us that an ounce of prevention is worth much more than a pound of cure. And I believe that. I believe that if you can prevent things from happening, then you don't have to cure them. And I also agree that we have an excellent, what I call sickness care system. We do a great job of treating illnesses. I've got a friend who's had 2 heart transplants and a kidney transplant, and he's got 2 jobs, works every day. I know people who've had amputations and yet they're functioning. But wouldn't it be great if we didn't have to have as many amputations? Wouldn't it be great if we didn't have to have as many sudden heart attacks that we didn't expect or we didn't know about? And so this prevention business, teaching people how to eat in one, and then using all of the therapies that I have a great dietitian, and I get a lot of information. Of course, my dad used to tell us that education is something that you do and not just something that you know. There are a lot of things that we know, but people are not doing them. And I guess what I'm really suggesting and recommending is that change is essentially a bottoms-up process. I've kind of studied this business of change a little bit, Terry. And I think that it is more bottoms-up than it is top-down. And while the information may be up a little bit, but somehow or another, we got to figure out how do we get to those individuals that we're talking about, that we're researching, how do we get, I almost cry every morning when I'm in Chicago because I pick up a newspaper at a little store. And when I go in this store, it's a service station, there are young mothers buying breakfast for their children. And they're buying hottie hots and, crinkle dinkles and, everything. And I mean, the guy does a great business. If I'm in there for 2 minutes or 5 minutes, he probably will have 100 customers. I mean, you can't get in the place. There are so many people. But these young mothers are not teaching their children healthy habits because they're buying them these little things. And I'm saying to myself, wouldn't it be great if they just kind of had some oatmeal and some grits and stuff or something and prepared for the kids before they went to school. And they'll have them, by the hand, and they're taking them to school, but they're giving them these things. I don't know how we really reach in a massive way the people that we're often talking about. When I think of the health centers and how they evolved and how they became, I think of the consumers who were such an intricate part. And I always thank God for a guy like Ted Kennedy, who made sure that the management of these places ended up with patience. You gotta have 51% of the board. I'm talking about the real deal. Gotta be patience, people who come here, who help decide what goes on here. So I guess my plea is to work with all of us to find a way to really reach that population group and somehow or another be able to help them buy into what we know. And what we know will benefit and help them. And I guess I'm on the ground enough to know that there's a lot of information, a lot of knowledge that never ever gets into practice by the individuals who could benefit the most from it. Thank you very much. I am delighted to be part of it.